Hello and welcome to Radcliffe Cardiology's webinar in association with Interventional Cardiology Review. I'm Harriet Seeger, the online editor for Radcliffe Cardiology, but I'm delighted to be joined today by Dr. Jacqueline Saw, Interventional Cardiology Clinical Associate Professor at Vancouver General Hospital, University of British Columbia. Many of you may already be familiar with Dr. Saw's work, but you can read Dr. Saw's full biography on our website. And just to mention here that Dr. Saw's also authored and co-authored over 100 publications, including scientific research studies, review articles and book chapters. She's also the editor of 2 textbooks on carotid artery stenting and a textbook on LAA Closure, which we'll talk about after the presentation. Dr. Saw, welcome.
Good morning, Harriet. Thank you so much for the introduction.
Well, thank you for joining us. And today Dr. Saw will be talking to us about percutaneous left atrial appendage closure. This is particularly topical because the FDA have recently approved the WATCHMAN device as an alternative to Warfarin to prevent stroke in patients with atrial fibrillation. You'll also have the opportunity to ask Dr. Saw questions via the text box on your screen throughout the course of the webinar, and Dr. Saw will answer as many as possible at the end. Dr. Saw will also be finishing with a case study demonstrating how the WATCHMAN device is implanted, which will be a strong and fascinating end to the webinar. So without further ado, I'll hand over to Dr. Saw.
Thank you again, Harriet. Thank you for having me here to discuss with you percutaneous left atrial appendage closure. So I will share with you an update about this procedure as well as recently published data and upcoming novel devices, and also to give you shed some light on the clinical relevance and indications of this procedure in your patients with atrial fibrillation. And these are my disclosures. I'm a consultant proctor and have received research grants from a couple of the companies who make left atrial appendage closure devices. Atrial fibrillation is the most common cardiac arrhythmia in adults. It affects 1 to 2% of the general population, and this prevalence is anticipated to increase substantially over the next few decades, doubling in incidence by 2050. In the setting of atrial fibrillation, the left atrial appendage undergoes functional as well as structural changes, including decreased contractility, enlargement, and together with the Virchow's triad events can result in thrombus formation. And in fact, when thrombi do develop in patients with non-valvular atrial fibrillation, in over 90% of cases, they are located in the left atrial appendage, which is a long blind-ended pouch with a lot of tuberculations. And in fact, the LAA has been labeled as the most lethal human attachment. We know that atrial fibrillation increases the risk of stroke by approximately 5-fold, and stringent guidelines have been established by several of the international committees, including the American College of Cardiology, which now recommends a chest VAS score of 2 or greater to institute anticoagulation, and the European Society of Cardiology with a chest VAS score of 1 or greater, except for women with lone atrial fibrillation. And the Canadian guidelines still adhere to the CHEST-1 score essentially, with the exception of lowering the age requirement to 65. Now, despite these international guidelines on anticoagulation, if you look at the global uptick of anticoagulation in the updated Garfield registry, you see that still, despite the availability of the novel agents or NOAC, there are still 40% of patients who are not on anticoagulation despite indications for anticoagulation. And indeed, if you look at the large randomized trials that compared NOAC to Warfarin, discontinuation rates of NOAC still range from 20 to 40%. And a lot of these discontinuations are due to bleeding events. In fact, major and minor bleeding events annually range from 14 to 21%, even with a NOAC. In terms of major bleeding, the annual incidence with NOAC still range from 2 to 4% as well. In fact, there are also other less tangible reasons for discontinuation of these agents, including drug intolerance, physician's decisions, and patient's decisions. Therefore, it's clear that a good proportion of patients may not be eligible for anticoagulation, and I've listed the common contraindications here, although it is debatable what is considered absolute and what are considered relative contraindications. And even if you were given a prescription for a novel agent such as dabigatran, in this recently published JAMA article, the adherence with medications was only 3/4. And even despite patients being on anticoagulation, there remains a residual annual stroke or systemic embolization risk of 1 to 3%. Therefore, even the NOACs are not a panacea for stroke prevention for AFib patients when 40% of eligible patients are actually not on anticoagulation because of intolerance. And there remains a residual bleeding risk, major bleeding of 2 to 4% annually, adherence of 74%, residual stroke risk, and there is still currently no antidotes for novel agents. Therefore, the NOAC are not a holy grail. And in fact, local strategies to exclude the atrial appendage has been explored for over 6 decades. Indeed, the first surgical excision of left atrial appendages was first performed in 1949, and percutaneous approach can be performed either through an endovascular approach or an epicardial approach. And this table lists the various devices available for endocardial and epicardial approach. The ones highlighted here in pink are the ones that have regulatory approval in a few countries. Now, just focusing on percutaneous devices for the remainder of the talk, the first device that was manufactured for LAA closure was the Plato device, which was first implanted in 2001 by Dr. Sievert. And even though the initial studies, the proof of concept studies, were quite promising, this device was nevertheless removed from the market for commercial reasons because of upcoming other devices. The second device that was manufactured specifically for LAA closure was a WATCHMAN device, which is initially manufactured by Artritech, which was subsequently bought over by Boston Scientific. And you see that this device first received CE mark in 2005, and is currently available in more than 50 countries, and 10,000 of these devices, more than 10,000 of these devices have been implanted. In fact, just recently, the FDA approved this device in March of 2015. You can see that there are 5 sizes with the WATCHMAN device, which is constructed of a nitinol frame and is covered by a PET membrane, which in animal models undergo complete endothelialization within 30 to 45 days typically. Now, when you look at the clinical trial data with this device, in fact, this device has a strong, robust clinical trial program, including randomized controlled trial studies. Currently, there are also ongoing global registries. So in aggregate, there are over 3,300 patients with more than 6,000 patient years of follow-up available with this device. I will review the 2 landmark randomized trials. The first is the PROTECT AF study, which in total included 800 patients, of which 93 were roll-in patients, and the remainder 707 patients were randomized in a 2-to-1 fashion to WATCHMAN versus Warfarin. And the threshold for indication was a CHATS score of 1 or greater. And the statistical design was by the Bayesian design, and patients were followed up to 5 years. Following WATCHMAN implantation, the typical anticoagulation regimen was aspirin together with warfarin for 6 weeks, and a TEE will be performed at 6 weeks. If there is no residual leak that was greater than 5 millimeters, patients will be downgraded from warfarin down to clopidogrel, together with aspirin out to 6 months. And then beyond 6 months, clopidogrel will be discontinued and patients continue on aspirin alone indefinitely. So when you look at the results for PROTECT AF, the mean CHATS score was 2.2. Amongst patients on warfarin, the time in therapeutic range was 70%, which is very good. And in terms of patients in the device arm, successful implant was achieved in 91% of patients. 86% were able to stop warfarin at 45 days, and 92% stopped warfarin at 6 months. The most recently published data was out to 3.8 years follow-up, and this was published in JAMA in 2014. The primary efficacy endpoint of stroke, systemic embolization, and cardiovascular death met both the non-inferiority as well as the superiority criteria with a risk ratio of 40% reduction. In fact, there was also an 85% reduction in hemorrhagic stroke and a roughly 60% reduction in disabling stroke, and as well a 60% reduction in cardiovascular mortality. In graphical form, then, the primary efficacy endpoint, again, there was a reduction here with device arm. Ischemic stroke, there was no difference between device and warfarin. Cardiovascular mortality was reduced by 60% with WATCHMAN. And all-cause mortality as well actually met statistical significance with a hazard ratio of 0.66. When we look at the primary safety events, which included procedural events and subsequent bleeding events, at a longer-term follow-up up to 3.8 years, the primary safety event was actually not different between device and warfarin. However, there was early concern with regards to serious pericardial effusion that required intervention, which occurred in 4.8% of cases initially. As well, there was a procedure-related ischemic stroke event of 1.1%, although the majority of these stroke events were related to air embolization, which with good training and experience actually essentially have been eliminated. Nevertheless, if you remove these peri-procedural ischemic stroke events, the actual ischemic stroke events that accrued in the remainder of the study were actually similar between the WATCHMAN group and the warfarin arm. Indeed, there is a definite learning curve with this procedure. This is a relatively complex procedure, which I'll show towards the end of this talk. But when you compare the early phase of PROTECT AF, which is the early half versus the late half of PROTECT, compared to the continued access registry or the CAP registry, if you look at the procedural time, it decreased from 67 minutes from the early experience of PROTECT down to 50 minutes with the continued access registry. As well, the implant success improved from 88% to 95%. Procedure-related safety events also reduced from 10% down to 3.7%. And pericardial effusion went down to 2.2% and procedural stroke down to 0%. Nevertheless, because of the initial early concerns regarding the safety events with WATCHMAN, the FDA mandated a second randomized trial, which is why the PREVAIL was conducted. This is a smaller randomized controlled trial inclusive of 407 patients. And so you can see that the inclusion criteria now has increased to higher stroke risk patients with CHAT score essentially of 2 or greater. As well, the FDA mandated that the study needs to have at least a quarter of the cases done by new operators and at least 20% of cases done by new sites. In terms of the results for PREVAIL, the technical or implant success improved to 95%, which was defined as deployment and release of the device in the left atrial appendage. The safety event as well came down to 2.2%, which was really quite acceptable. When you look at the vascular complications, which are defined here in this slide, the 7-day serious procedure-related events also came down to 4.4% compared to early experience in PROTECT, and there were no procedural deaths reported in any of these studies. In terms of pericardial effusion, those requiring pericardiocentesis or window was only 1.5% in PREVAIL, and cardiac perforation requiring surgical repair was 0.4%. In terms of ischemic stroke, in PREVAIL, it also was significantly lower compared to earlier studies with PROTECT. It's down to 0.4%. PREVAIL actually included 2 other primary efficacy endpoints as well, aside from the early safety, which met the non-inferiority criteria. In the published data in JACC in 2014, the primary efficacy endpoint, 18 months stroke, systemic embolization, and cardiovascular death actually did not meet the non-inferiority upper boundary. But when you do look at the event rates, it was 0.064 versus 0.063, which were very similar. And the reasons likely for this not meeting non-inferiority was explained by the authors is likely related to a very good warfarin control arm. When you look at the PREVAIL ischemic stroke rate, it was only 0.7%, which is much lower compared to contemporary NOAC studies, which range from 1.6 to 2.2%. Nevertheless, based upon the PREVAIL as well as the PROTECT AF results, the FDA finally gave approval to this device on March 13, 2015, just before ACC this year. And these are the actual indication by the FDA. So WATCHMAN is indicated to reduce the risk of thromboembolism from the left atrial appendage in patients with non-valvular AFib who are at increased risk of stroke based upon the CHATS score or the CHATS-VAS score. And they have to be also deemed by the physicians to be suitable for warfarin, but yet have an appropriate rationale to seek a non-pharmacologic alternative to warfarin. Now, just a couple of moments here to talk about the ACEP study, which is relevant for patients who are contraindicated to antithrombotic therapy. So this is a multi-center prospective non-randomized study in patients with non-valvular AFib with CHATS score of 1 or greater, and yet they are ineligible for anticoagulation. You can see that 93% of patients had prior major bleeding events or bleeding tendencies. In these patients, 150 patients underwent WATCHMAN implants, and they were then continued on dual antiplatelet therapy for 6 months post-procedure. What they found in this study was a 77% reduction in ischemic strokes when compared to the expected rates based upon their CHATS score. Now, the data I've shown so far revolves around the 2nd generation device. The 5th generation device, called the WATCHMAN Flex, is awaiting first implantation over the next few weeks. And this device has a few new features, including involuted feet, which are potentially less traumatic in terms of decreasing the risk of perforation and pericardial effusion. It's also fully recapturable and redeployable. And also there are more nitinol frames as well for better conformation to the atrial appendages. So we look forward to more results of this new generation of the device. Now, the third LAA device that was manufactured specifically for the left atrial appendage is the Amplatzer cardiac plug device. This device is not FDA approved yet, but has received CE mark in December 2008. And globally, there's also been more than 10,000 of these devices that have been implanted. This device is a little bit different from the WATCHMAN device, which is more of a single lobe design. The ACP, on the other hand, is more of a 2-lobe design. It has a distal lobe that is meant to be implanted in the proximal portion of the left atrial appendage, and then a disc that is more proximal, and this is meant to be placed in the left atrium to cover the orifice of the left atrial appendage. And there is a polyester mesh that is sewn by hand into both the lobe and the disc. Now, this device comes in 8 different sizes and also is retrievable and redeployable until you're satisfied with the position. There is currently no randomized controlled data with the Amplatzer devices. However, several countries and several regions, I should say, have published their own registries and outcomes. As you can see here, over 1,000 patients have been reported in these registries with very similar outcomes in terms of procedural success and complication rates compared to the WATCHMAN device. Perhaps the best data we have so far with Amplatzer is the series published by Apostolus Vicus in Euro Intervention this year. And this multi-center pool analysis included over 1,000 patients from Europe and Canada. And patients were recommended to be on dual antiplatelet therapy for 1 to 3 months after device implantation. The outcomes with regards to stroke was 2.3% at follow-up, which is approximately a 60% reduction compared to estimated when compared to estimated rate based upon their CHATS-VAS score. As well, there was a 60% reduction in major bleeding events when compared to estimated rates based upon the HES-BLED score. There's also a 2nd generation of the ACP device. It's called the Amulet device, which has a wider lobe, more stabilizing wires, as well as larger sizes to cover larger appendages. And this device has also received a CE mark last year and currently available. Even though there's no current randomized controlled data for these devices by the Amplatzer, for the Amplatzer devices, there is a, the company, St. Jude Medical, is constructing a non-inferiority study to compare Amulet to the WATCHMAN device. So stay tuned for the launch of that study. The third device, I should say the fourth device, but it's the third, I guess, most leading device in terms of percutaneous devices implanted worldwide is the Lariat procedure. Although the volume is much lower in comparison to the WATCHMAN and the ACP devices, the Lariat procedure is a little bit more complex compared to the endovascular approach. This requires both an endocardial as well as an epicardial approach, meaning a pericardial access has to be obtained and a 14 French sheath placed through the pericardial space. You can see from this video here that this is a relatively complex procedure that involves transseptal puncture and a magnet that is placed both inside the atrial appendage and outside the appendage, and then using a lasso to loop over this magnet, and then cinching on the lasso when appropriate position is obtained, and then the endocardial magnet is then removed, and complete cinching of the snare is then performed and then released. This device did receive FDA approval through the 510K process for tissue apposition, but not specifically for AFib patients. But nevertheless, has been used for that purpose because for over a year there were no other devices available until WATCHMAN was approved. Even though the initial results with the Lariat procedure from a single center registry was promising, subsequent data from pooled analysis, including this by Matt Price published in JACC, showed some concern, including a procedure success rate of only 86%, and also major complications of about 10%, which are mostly related to major bleeding events of 9%, significant pericardial effusion in 10%, and also death, MI, and stroke in 3%. In another smaller series here of 41 patients, likewise, there were concerns about pericardial effusion in 20% of patients, including 9% with cardiac perforation and 17% with pericarditis. And in fact, just this week in JAMA, Chatterjee and colleagues published their review, systematic review, which included 309 patients of published results on the Lariat device. And the incidence in terms of need for urgent cardiac surgery was reported to be 2.3% and mortality of 0.3% and procedure success of 90%. And therefore, even though this epicardial approach may appear promising because no device was left behind, however, there are a lot of downsides potentially with this device because of the more invasive nature of this procedure. Is more complex. It takes longer with an average duration of about 2 hours of this procedure. And currently there is no long-term efficacy data as well. So this company as well is devising a non-inferiority comparison to WATCHMAN. So do stay tuned for future results. Now, in terms of other novel devices that are up and coming, the third endovascular device that received CE mark was the WaveCrest device, which received CE mark in September 2013. As this device is quite nice in terms of having anchors that can be separately deployed after the initial device was implanted. And it comes in 3 different sizes. And the first implant was performed in 2012. The early feasibility study of 73 patients, the results look very promising. As well, this device will be undergoing a non-inferiority comparison to WATCHMAN in the ensuing few months. Other devices, just briefly, the Alember device by LifeTech can be deployed through relatively small sheaths of 8 to 10 French. This first in men was performed in Asia. There's an ongoing CE mark study. You can see this device has a two-component design similar to the Amplatzer cardiac plug. The Aquatect occluder utilize loops for anchoring as opposed to using hooks. Interesting device as well. It's again undergoing CE mark study, and hopefully approval over the next few months. The Ultracept device by Cardia, as well as a two-prong type of a device, can be deployed through 10 to 12 French sheaths. Again, a CE mark study is ongoing. And there's another device called a PFM device, which also has two components. Preclinical studies have been done. It can be deployed through relatively small sheaths, 9 to 10 French. And then finally, there is even the Sideris Patch, which allows administration of essentially glue to seal up the atrial appendage. There have been a small series of human implants that perform with this device. And just moving on to potential LAA closure device-specific issues, I've alluded to earlier what the procedural complications may be, and that includes pericardial effusion that requires drainage, which with modern day in experienced hands is roughly 1% or less, and the incidence of cardiac perforation less than 0.5%. Procedural stroke essentially approaches 0%, and device embolization, I'll address this in the next couple of slides. There are also late potential device-related issues such as device-associated thrombus and peri-device leak. In terms of device embolization for the WATCHMAN device, in reported series, it ranged from 0% to 1.3%. On average, is 0.6%. For the ACP device, it ranges between 1 to 2%, with more contemporary series here by Zickus, roughly 1%. And so when device embolization occur, typically they can be retrieved through percutaneous means. In terms of longer-term potential issues, device-associated thrombus, each of these devices have had reports of device-associated thrombus, which occurs in 2 to 5% of cases, and they tend to occur predominantly on the non-endothelialized protrusions of these devices, which includes the end screw of the ACP and the threaded insert with the WATCHMAN. And also they typically tend to occur with implants which are too deep. Most of these thrombus that occur on these devices are treated with anticoagulation for 6 to 8 weeks and usually have no clinical sequelae. You can see in the PROTECT AF and AFib studies, the incidence of thrombus was 4% on follow-up TEEs, but the incidence of stroke related to these thrombus was much less than 1%. In terms of peri-device leak, the incidence depends on the device that you're looking at. The WATCHMAN, up to a third of the peri-device leaks has been reported. However, in post-hoc analyses, these peri-device leaks were not associated with thromboembolic risk. With the ACP device, we're seeing peri-device leak in perhaps 10 to 12% of cases, and with LARIAT devices between 2 to 22%. So really varies depending upon the definitions used. But for the most part, even though peri-device leak may occur, it has not been associated with long-term cardioembolic events. So what are the current indications for LAA closure? If you look at the national guidelines that have been published, the ESC in 2012 gave LAA closure a Class 2B indication, which they indicated can be considered in patients at high stroke risk and contraindications for long-term oral anticoagulation. Likewise, the NICE guidelines in 2014 reflected those recommendations where LAA closure can be considered in patients if anticoagulation is contraindicated or not tolerated. In the 2014 consensus European guidelines by the Heart Rhythm Society and the PCS Society, the recommendations were more lenient, if you will, which included patients with contraindications for oral anticoagulation, or patients refusing to take these oral anticoagulations, and also included patients who are at increased risk of bleeding, as reviewed through their HES-BLED score and other indications. So these patients would be appropriate for consideration for LAA closure. So here, just in summary of what I've talked about so far, atrial fibrillation is prevalent, but approximately 40% of eligible patients are not on anticoagulation despite the novel agents. And to date, based upon randomized trials, the WATCHMAN device is safe and effective as an alternative to anticoagulation for patients with non-valvular AFib for stroke prevention. And recently, the FDA approved the WATCHMAN device for Warfarin eligible patients, even though international experience currently are mostly for patients who are not eligible for anticoagulation or who are at high bleeding risk. And there are a few novel devices in the pipeline which may provide better procedural safety, ease of implant, and potentially lower device-associated risk, but currently ongoing registries as well as anticipated non-inferiority randomized trials will be performed. I think we have a few more minutes here where I can actually review a case example with you. So this is a standard example of a case that we do in Canada, essentially for patients who are not candidates for long-term anticoagulation. So this is an 83-year-old woman with permanent atrial fibrillation, CHAS score of 3 and a CHAS best score of 5. She was previously on Warfarin, except she had recurrent GI bleeding over the past year, including requirements for transfusions. Her Warfarin was discontinued, and she was not even instituted on aspirin therapy initially. She has several other comorbidities. We typically perform these procedures with a baseline screening with both a TEE as well as a cardiac CTA. And this example here illustrates the anatomy of this appendage that we can visualize very well on CT, and we can even do volume rendering images to really appreciate the complexity of the atrial appendage and the trabeculations. During the procedure itself, these are typically done under general anesthesia at our institution. So a TEE is performed after patient has had their GA, and so we do preliminary measurements of the sizing. After volume bolusing, you can see the atrial appendage orifice was measured to approximately 1.6 to 1.7 centimeters on the baseline TEE. Once we rule out thrombus in the left atrial appendage, then we proceed to doing the transseptal puncture, which for this procedure, we really try to aim with an inferior-posterior puncture at a fossa ovalis to allow us a more coaxial approach to the left atrial appendage, which is typically more of a superior and anterior structure. So we do this on TEE, looking at both the bicable views as well as the short axis view. Now, in this patient example here, we puncture across the atrial septum in a short axis view using a BRK extra sharp needle. Once we have access with transseptal puncture, we place a super stiff Amplatzer wire into the left upper pulmonary vein and advance the WATCHMAN 14 French sheath across the septum. And this sheath, typically, we have a few choices. The one that we're using here is the double curve sheath. You can see sometimes there may be challenge getting across the large sheath across the atrial septum, which is why it's important to have a stiff wire up in the left upper pulmonary vein. Once we have positioned the sheath across the septum, we use a pigtail to gently navigate our system into the left atrial appendage. And here's an example here where we've taken a cine angiogram with a marker pigtail, and you can see the structure here. This atrial appendage is quite similar to what we've seen on the baseline CT images. So we would obtain fluoroscopic measurements. In this case, you can see the orifice was measured at about 20 millimeters, and quite similar to what we obtained on CT. So we selected a 24 millimeter device. In preparation for device deployment, we advanced the WATCHMAN sheath distally into the atrial appendage through the pigtail position to try and minimize any trauma to the thin-walled atrial appendage. Once we're happy with the position of the sheath, we would then remove the pigtail and advance the device in position. So deployment of this device is through a withdrawal maneuver of the sheath itself. So essentially, the right hand holds the cable still, and the left hand pulls the delivery sheath back to basically unberth or unsheath the device. As you can see here, the device essentially popping out with the withdrawal maneuver. Now, in this example here, we've taken a contrast injection. You can see that the device is quite deep, so there are there are a couple of maneuvers you can do to move the device back. The WATCHMAN device may be partially recaptured and deployed, and it also can be fully recaptured if you're not happy with the size. So this is an example here showing a partial recapture of this device, and then we move the sheath back slightly by 1 to 2 millimeters, and then we can redeploy this device as shown here in this image. So redeployment from a partial recapture position in a more proximal location. We can observe these deployment on TEE, which allows us a good image of the atrial appendage with regards to the proximal trabeculations and other potential challenging features that might impede deployment. Following that partial recapture, we took a cine angiogram again to check the position, and we also want to check the stability of the device, and to do so, a Tug Test is typically performed, and sometimes we do 2 or 3 Tug Tests to make sure that the device is safe. And here what you're seeing is a movement back by pulling the cable and letting the device bounce back into position, and you can see that this device is very safe. It's entrenched in the left atrial appendage. And we observe this motion both on cine angiogram as well as on TEE, and we then perform another injection again here to see the device has moved and the device has not moved in position. So once we're happy with the stability of the device, we would evaluate the compression of this device and for any peri-device leak. So we would do so on TEE at 4 different views. At 0 degrees, you can see that there is no peri-device leak. We measure the shoulder of the device, which for this 24 millimeter device, in this view is measured at 1.7 centimeters. We then go to the 45-degree angle, and again, evaluating for any peri-device leak, and also measuring the shoulder for compression, and at this view was 1.57 centimeters. We then go to the 90-degree view, again looking for any peri-device leak, and the compression measurement here was 1.64. And then finally at the 135 view, again looking for any peri-device leak, and the compression measurement here was 1.5. Now, just to keep note that before any release of device, we do not want to see any peri-device leak that is more than 5 millimeters for sure. And typically, we accept up to 3 millimeters of leak. If we're not happy with that, we would reposition the device. So based upon our compression measurements, we like to, for a 24 millimeter device, we like to achieve a compression measurement between 19 to 22 at a minimum, and most of the measurements we had were less than 19, which means that the device is well compressed. And we certainly, based upon the instruction for use, we want to have a compression of 8 to 20%, which was achieved here. So we look at these 4 criteria: pass criteria, position, anchor based upon a Tug Test, sizing, where the compression of the device is 8 to 20% of original device size, and then seal, meaning there's no significant device leak of more than 5 millimeters. And if all these criteria were achieved, then we would release the device. And so we like to have a 3D image of the device prior to release as well. So you can see here slight protrusion of the shoulder device outside of the atrial appendage, which is acceptable. And so once we're happy with meeting the pass criteria, you can see here we counterclock to release the cable from the device, and then we take a final cine angiogram image of this, and the procedure then concludes. Overall, the procedure takes roughly about an hour to an hour and a half, and that was the case example. Thank you.
Well,
Harriet, I'm happy to take any questions.
That's super. Thanks so much for your comprehensive and excellent presentation. Yes, we have had a few questions in, so if I start at the beginning. The first question was, are these procedures done under general anaesthesia or local anaesthetics? And are there other means for imaging the LAA aside from TEE during the procedure?
Right. That's a great question. What we routinely in our center would perform these procedures under general anesthesia and typically with TEE guidance. And this predominantly is the practice in most centers throughout the world, although there are a small series of centers, less than 5% or so, which utilize intracardiac ultrasound, or the ICE, to image the atrial appendage instead of TEE. And in those settings, general anesthesia can be avoided, but most centers are more comfortable using TEE because of the superior image that is obtained compared to ICE images. The atrial appendage, unfortunately, is quite difficult to image with the ICE, and you need special positions to place the ICE probe to image the atrial appendage, including doing a second transseptal puncture or getting into the RVOT, for instance. So it's a bit more challenging than a standard ICE for ASD or PFO closure, and most operators are not comfortable doing ICE for this procedure. So the majority of operators globally tend to utilize TEE, and to do so usually would require general anesthesia.
Okay, thank you for the answer there. The next question we've had is, what is the average duration of stay following the procedure?
That's a good question. Typically, our patients stay overnight for observation, just because they're recovering from general anesthesia, and also it also allows us the opportunity to perform a transthoracic ultrasound the following day to make sure that the device is in position. When we do see device embolization, it tends to occur either during the procedure or within the first 24 hours. And so it allows us to ensure that, well, number one, the device is still in position, and number two, that the patient has not accumulated pericardial effusion over the 24 hours post-procedure, and we can rectify that if necessary. So typically the average stay is just an overnight stay.
That's potentially very short then, that's without complications. So
that's right.
One more question we've got is, what is the antithrombotic regimen after device implantation?
Right. So that would depend on the patient's indications to begin with. In the PROTECT AF study and the PREVAIL study, because these randomized studies were done in patients who were eligible for anticoagulation, so the routine following WATCHMAN in those patients would be a warfarin for 45 days, and then a TEE is performed. If the TEE does not show a peri-device leak of more than 5 millimeters, then they can be downgraded from warfarin down to clopidogrel, which then continues out to 6 months in total, and an aspirin is instituted throughout the whole duration. So typically aspirin and warfarin for 45 days, and then aspirin and clopidogrel out to 6 months, and then beyond that is aspirin alone, and that is for eligible patients for anticoagulation. Okay. Now, for most parts of the world who are implanting WATCHMAN for patients who are not eligible for anticoagulation, that includes us here in Canada, a routine will be to institute dual antiplatelet therapy. So that will be aspirin and clopidogrel after WATCHMAN implantation. And the duration of that therapy then really depends on operator decision, but it typically ranges between 3 months to 6 months of clopidogrel and aspirin indefinitely.
Okay. May I ask also what's the average duration of the procedure?
Right. The average duration of the procedure, well, that sort of depends on the complexity of the atrial appendage and the transseptal puncture. But what we find on average with WATCHMAN is from the femoral puncture to device release ranges between 30 minutes to 60 minutes. So it can be relatively short.
Mm-hmm. Okay. And one final question, what is the current patient population who receives this procedure globally?
for most parts of the world, the majority of patients who receive an LAA closure are currently patients with contraindications to anticoagulation long term, or they are at high risk of bleeding. In the United States, with the recent FDA approval, the indication is for patients who are eligible for warfarin, and yet, you might have alternate reasons to search to implement device therapy versus anticoagulation. So that might be patients who may not be adherent to anticoagulation or who participate in some high impact type sports, etc. So the indications are quite broad globally, but I would say for the most part, in outside of the United States, is majority for patients who are contraindicated to long-term anticoagulation.
Okay, so we're going to see the numbers rise over the coming years in terms of numbers of people. Okay, one other thing I wanted to mention was your new book. It's called Left Atrial Appendage Closure, Mechanical Approaches to Stroke Prevention in Atrial Fibrillation. Has this just been published, Dr. Saw?
Right. It will be available should be available at TCT this year. So it's in the works currently. So it's just a few months out for until the actual copy is available. So it should be available by September this year.
Okay, do we have a link to the Amazon site which we put on the site? So presumably, can they pre-order the book or?
I think so, yeah.
Okay.
It's by Springer, so I think there is that opportunity, yes.
Okay, that's fantastic. Well, thanks so much for joining us today, Dr.
Perfect. I do see there are a couple of other questions from the audience about if the device embolizes, how do you retrieve it? That's an interesting question. I gave a talk on that in Berlin recently this year as well. Device embolization can occur, as I mentioned in my talk. It occurs in about 1% of cases overall. How do we retrieve it? Typically, we retrieve it percutaneously using a large sheath that is, typically 2 French sizes larger than the deployment sheath. So typically somewhere between 14 to 16 French sheath, and we use a lasso. So we use a gooseneck snare over a 5 French guide catheter, and we're typically able to snare the device back either through hooking the end screw of the Amplatzer device, or if you need be, hooking on to one of the foot pedals of the WATCHMAN device. And these devices have been successfully retrieved percutaneously.
That's super. Actually, we've had a couple of other questions coming. I think if we got a time for one more, which is this device MRI compatible?
Yes, these devices are.
Okay. And I think we've had a duplicate question, is what is the anticoagulant recommendation of the WATCHMAN device implantation? But I think you've probably covered most of that now.
Yes, we've addressed that.
Super.
Very good.
Well, that's fantastic. Thanks so much for joining us today, Dr. Saw. That was excellent. And thank you also to our viewers for joining us. Until next time.
Thank you so much.
Thank you and goodbye.
Thank you. All right, bye-bye.
Bye-bye.